And we're live. Hello, LinkedIn. This is Marion Spears Carr, and you're watching the Healthcare Thought Leadership LinkedIn live show on a special time and date. Normally, we're on Fridays at lunchtime, but we wanted to get a show in this week, and a lot of things have been happening and going. A lot of travel. I was at VCU last week. I was just at an HFMA conference last week. The week before, I was teaching with an organization here in Atlanta. Glad to have you. If you're new to the show, please let us know where you're watching in the comments. And if you have questions, please do so. Today, we're excited, very excited to have my friend Gail Zahtz on the show to talk about mastering value-based care through her healthBZ.Academy. Gail, say hello and introduce yourself to the audience.
Hi, and I'm already getting highs in the chats. I'm so excited. Hi, friends.
Absolutely.
Hi, Gail Zahtz.
Good.
Thank you for having me. I'm super excited.
We're glad to have you. And Gail, you and I met through a networking group that you and I are a part of, and was really very excited when you and I connected because in the area of executive search work that I do, I work with traditional healthcare and hospital systems, but also in the private equity space. And a lot of our private equity clients are really paying attention to the value-based care model, how that's going to have an impact on reimbursement, what organizations are going to have to do in terms of changing the care delivery process, all those different pieces. But one of the things that might be a good way to start is for you to maybe just give us like a 2-second primer on what it really means, because there's a lot of misinformation about value-based care. I'd love for you to just kind of set the table. And if you're watching live, let us know in the comments where you're watching. What do you think, Gail?
Yeah, no. Hi, Miami and Tucson. Just so I'll give you a quick Gail Zahtz the way I explain it, right? Because to understand value-based care, where are we going? Let's understand where we're coming from, right? So where we're coming from is fee for service, or as I like to call it, fee for sickness, which is right, which reimburses volume. So what does that mean? I'm walking on a sidewalk, and the sidewalk's all broken, right? And I trip and I fall and I bust up my arm. And then I'm going to the hospital and I get a bill, right, that I have to pay for each part of the service, for scanning it, for reading it, for physical therapy after. Each one of those is a fee for the sickness. Yep. And so all of healthcare is geared towards paying this way. You get a ticket for treating somebody, just like a mechanic, a service for somebody being sick. Only that doesn't keep anybody healthy, right? Because it means that I'm going to get paid only if I know you're going to fall. So I kind of want you to fall.
Yeah, I kind of want you to fall.
Right?
Exactly.
So there's no incentive for me to fix that sidewalk. Yeah. Value-based care says, I'm going to pay you regardless. I'm going to pay the doctor even if Gail does not come in. So now you want to keep that sidewalk safe. Because now if I don't fall, you're going to make even more money. And health equity says that there needs to be a safe sidewalk in every single neighborhood, regardless of race, regardless of socioeconomic. Everybody should have a safe sidewalk and be able to stay healthy at home. Does that help make sense of it?
Absolutely. And I love that. I love that analogy and explaining. So one of the things that I got excited about when I started paying attention to the whole movement was this idea around how, as we move into the value-based care space, and you already mentioned it, that from a health equity perspective, we can start identifying at-risk populations, understanding why they need to be managed, how they can be helped, et cetera. And a lot of the companies we work with are in that space. And by the way, there's a lot of people checking in. Romy is checking in from Miami. I know it's beautiful down there. Susan in Tucson. Trent Good, my friend Trent, checking in from Atlanta. Lindsay's also checking in from Alpharetta, Georgia. Dr. Kamar's checking in from India. That is awesome. Glad to have you in the audience. My friend Karina's out in San Francisco. She's an ACHE compatriot of mine. And thanks for correcting the spelling of my name. It's okay. It pronounces the same way, Karina. It's okay. Deanna's checking in from Dammers, New York City. Oh, that's her last name. New York City. And Cheyenne also checking in from Elk City, Oklahoma. So one of the things that you do, you're a keynote speaker. You've spoken and led groups across the country. One of the things you're trying to do now is equip healthcare leaders to understand the challenges of value-based care and to be prepared for that. And that's what we want to talk about. What are some of the key things you think that leaders in the healthcare market right now are missing when it comes to the movement to this payer model as we continue? And we're being drugged through it in some ways, right? It's not like everybody's like, oh, we're going to do that. It's going to be great. It's not. It changes the whole business model. But what are some of the challenges that leaders are facing right now, or maybe some pitfalls that they don't even understand that they're missing?
Well, I think you kind of hit it, right, when you said that we just actually have to change everything, right? So The technology systems are all, EHRs are all built for fee-for-service billing. The entire EHR is built for that. So you have to look at all of your technology, your workflow. The biggest is that we're talking about building a health system without walls. Mm-hmm. So anything that you're providing, whether it's a service or a solution or healthcare or even the infrastructure, right now is geared towards that visit. You're going to come in, we're going to note that there was an episode, a visit, and then we know what to do with that. The goal in value-based care is a health system without walls. It says that if I'm your physician, I can treat you at Starbucks. I can talk to your significant other and help work things out. I can send a fax or a text or it's no longer about that visit, which has never worked for patients, and it hasn't worked for physicians either. So what are the big pieces in what you do that can support health system without walls? So you look at the patient journey is very different. Communication has to be different, and communication needs to be compliant, which is so different. So I look at kind of like some key building blocks, which is your primary care, compliance, community and faith-based organizations, patient experience and engagement, and sort of all of these pieces that support it. So I think that pretty much you just have to look at the whole organization.
Yeah, absolutely. And Michael Bonham is checking in, and I really thanks for the correction. But sometimes they are lying for the care of the sidewalk. Who is lying for the sidewalk? You admit paying that is. Let's talk about the payer model here, because all this sounds great. That keeping people healthy, making sure that they have access, making sure that they're being taken care of in a more holistic way and improving their life. But let's cut right to the chase. How's it going to get paid for? And understanding that whole model might be helpful too. And I'm assuming you talk about that in your academy as well.
Yeah, I mean, I really came to this when I had this aha moment that if we change the financials, we can incentivize people to do the right thing. So in my opinion, it's all about the money, because that gives us the opportunity. And so right now, the way it works is you bill a payer, which would be CMS. The government is the biggest payer in the country, Centers for Medicare and Medicaid Services, or an employer self-pay plan, which the majority of people who get their insurance from their work are actually on a self-funded plan. They don't know it. Or your traditional payers, United Health Group, etc. All of those, regardless of the model, usually pays when somebody bills. A physician bills for this service. With value-based care, you move away from that and into the goal being a full upside downside capitation, which is like a subscription that says a PMPM, maybe you've heard of that, per member per month, that says that we're going to give you, and this would come from the same sources. So CMS will pay the intermediary some kind of monthly is the goal. That's what we're seeing move towards, is this capitation. And then if you provide lower cost of care, you keep the difference. Exactly. And if you don't, then you're on the hook for it.
That's a good point. Some other people are checking in. Cindy is checking in from New York. You got a lot of fans checking in. Let's see. I saw Dr. Escher. I can't pronounce. Aaron Singh, checking in from New Orleans. Can't wait to feel your passion. And obviously, you're jacked up like I am. We've probably been drinking way too much coffee. When Gail and I first met, we were on a conference call with a lot of other people, and I'm afraid a lot of other people probably thought we were losing our minds because we just like, I had an idea, she had an idea, I had an idea. It was kind of back and forth. So if you have questions for Gail, please post them in the comments. We'll try to get to those. So tell me about this academy you're creating, and tell us a little bit about how that process works. And really, what's the, obviously we've kind of established a little bit about the problem to be solved, but go a little bit deeper about how you're solving this problem of getting people prepared as leaders through the academy.
This is such a passion of mine. Thank you so much. So, I a couple of years ago, I realized that being responsible for lives, for individual lives, my impact was going to be limited, right? Which, so if you work for a payer provider, you have X number of lives. And I started working with clients. And when I realized that to move this ship, like you're talking about, required a massive amount of learning and figuring out how to make those changes, right? The average person wants to understand this stuff, but where would they have gotten it, right? Like, who is teaching somebody the finite pieces of a prospective payment system for inpatient and how that's different than a retrospective payment system for post-acute? There's all of this minutia. And what did I find? I found that over 65% of the people who report on health don't even have the basic fundamental knowledge of the pieces of healthcare that they're reporting on. So I don't know if
we've lost your audio there for a moment. I think your audio went out a little bit. I want to jump in here while we're trying to get your audio back up. And this is the beauty of live LinkedIn right here. If the audio is not working, Gail, you might have to go out and come back in like we did earlier. One of the things I wanted to share with everyone in the on the show is one of the things that I've tried to do with healthcare thought leadership was to highlight people like Gail who are out there working in educating people in the value-based care space and med device, life sciences. Those are the areas that I work. And one of there, we got her coming back here. Let's see. Let's check your audio. There we are. We're back. There's live for you.
Oh, thank you, everybody.
I would just share with them that one of the reasons I started healthcare thought leadership a year and a half, almost 2 years ago, was because there's so much information out there, and there's so many thought leaders in so many different aspects of healthcare delivery, life sciences, med device, diagnostics. I just wanted to share my network with my network. So that's what this was all about. So let me ask this question. Somebody, Dr. Kumar mentioned that, love the mention of patient experience. One of the things I've looked at quite a bit, and as somebody that's been in healthcare executive search for 30 plus years, I hate to mention how long, tells everyone how old I am. One of the things I've always seen, and also being a patient, I've also seen a lot of patient experiences are hampered or caused to not be as strong because the patient themselves don't have a high level of health literacy. And I'm really curious about, and again, I'm probably redirecting the conversation for a minute, but as we think about value-based care, what are some things as leaders learn about the model, learn about the new deliveries that they can do to help consumers understand why the shift's taking place and why it's going to be a value? Because let's face it, a lot of people are not going to the doctors right now because they don't know enough to go, and they've been scared by the COVID situation and the whole pandemic. I'd love for you to talk a little bit about that. I know that's a little bit off the conversation.
No, but let's take it.
I think it's important.
Let's take it back. How about if the patients and the doctors had access to their own data?
Massive.
Right?
Yeah.
Now, we've been talking about that for a long time. So, but when you financially incentivize doing the right thing, it makes sense to make that data available and to prioritize it. So with value-based care, you're going to start seeing really integrated patient apps. You see that you have to have a physician dashboard. If you're running value-based contracting and you're not including and telling your physicians what's going on, then shame on you, right? Like, this is supposed to be a joint effort. And who is it? It is who's paying, it is who is giving services, the provider, and it is who is receiving services and wants to be incentivized to be part of the process, which is the patient, right? So this gives us the opportunity to give that access to everything. Let's just kind of walk it through how value-based care would work with the patient understanding what's going on. So I get out of the hospital, I'm now home, I get a call. Why do I get a call? Because it's value-based care. So they're going to have like a call center and they're going to care about what's going on. They're going to call me and they're going to say, oh, are you taking your medicine? No. Well, why aren't you taking your medicine? I didn't get it. Okay, let's fix that. Let's get it delivered right now while you're on the phone. No, I'm not taking my insulin because I can't store it in my fridge because my fridge isn't working. All right, well, let's talk about getting your fridge fixed. No, I can't take it because I couldn't get to the follow-up appointment. Let's get you transportation, right? We start looking at all these social determinant pieces. We also look at the fact that you can now connect that person and say, let's talk to a pharmacist on the call right now. Oh, it's about your diet because you're a diabetic. Let's talk to a dietitian right now. Let's connect that to food delivery from your local food bag that is nutritious and healthy. So I think that part of it is that, right, I was a patient. I mean, we're all patients all the time, but whatever. But I was, for those who don't know, living in a nursing home, blind, on liquid-only nutrition, in an electric wheelchair, refused to go to hospice. So, and during that time, it was not an issue of somebody telling me, it wasn't about me reading something, you need to understand more about what's going on. It's about being part of the process. And right now, no one is part of the process, and I'm interested to hear the thing that somebody just posted about transparency. So it's fair to
I'll
say
bring
the
that
patient
question up. Yeah, so here's the question.
Oh, perfect. Thank you.
Fair to say that patient has more transparency in this model, provider has more accountability, and payer is able to improve on equity.
So I'm glad you put that up because yes, everybody read that. Yes, we have more transparency. We have more accountability. We should all be accountable. And the motivation is that it saves money. AAA, lower the total cost of care, improve the outcomes for patients, and improve the patient experience. Everything that happens in value-based care is supposed to be towards the AAA.
And I want to come back to that. One of the things that you mentioned earlier, and there's a comment from Cindy I want to post up about how complex this whole situation is, and the fact that you're educating people is what we're talking about. Gail agrees. You're to that point. You're so right, Gail. It's simply overwhelming for almost everyone in the healthcare space right now. Even if they want to do the right thing, understanding where to start, understanding where to get information. Also,
and can I cut in? This is why I decided to do
I'm just excited about
Cindy.
that comment.
No, I'm super excited too. I want to respond to that. Thank you, Cindy. This is it, right? So what I found myself doing is, training my clients at tens of thousands of dollars in closed door trainings to try to get them up to speed, because you can't fix what you don't understand how it's working, right? And very few people actually understand the business of healthcare. And it's not your fault. It's because most of the people who understand how the business of healthcare works have no incentive to educate the change makers. Most of the people who understand how the business of healthcare works have no incentive to educate us. And for those who know me, you understand that just wasn't good enough for me, right? And so I said, I cannot fix healthcare. I cannot fix healthcare. It's too broken. It's not a one-person job. So what I can do is I actually really, really, really understand how it's working, or how it's pretending to work, and how we fix that with the pieces of what's available to us right now. And so, For those who've heard me talk, I talk a lot about like our superpowers, and what we can do for ourselves. And I say that our biggest superpower is where you take our experience and life and knowledge and passions, and it intersects with what the world needs most from us.
I love that. So let me reset the room for a minute, because you and I are
Yeah.
getting so excited. For those of you out there, you might want to turn the volume down just a little bit, because I think we're yelling. That's okay. Those of you who don't know what you're watching and have just checked in for the first time, this is Healthcare Thought Leadership. It's my bi-weekly. I used to do it weekly, but with everything going on, we're going to twice a week. My Healthcare Thought Leadership LinkedIn live show that I get to meet and introduce these great people in my network and what they're working on and how they're doing what they're doing to make the industry better across a lot of different segments. So it's a great opportunity to have these conversations. We love the live comments. So please, if you have more questions, we have about.
I really like it. Like I'll say as long as people keep commenting.
Exactly. These a lot of times my show, Gail, FYI, a lot of times there's two shows going on. There's me and you, and then there's the show in the comments. So it's always good stuff. Let's go back to a point that I really want to dig down in a little bit. One of the under fee for service, there is this access issue, particularly at risk populations.
Yeah.
Talk to me a little bit more about understanding the data, because I think understanding where more companies are getting into the data space. Obviously there's technology already out there, but there's companies like HS Blocks in Atlanta that's really helping organizations understand this disparate data and identify which populations are more at risk. Talk about identifying at-risk populations and how understanding the value-based care and the risk models are going to help them over time.
Love this question. Okay, so let's look at it this way. So we're going to look at dual eligibles. A dual eligible is somebody who is eligible for both Medicare and Medicaid. Doesn't mean they're getting both. So what that means is they're over 65 or permanently disabled and at some level of poverty. Okay? Dual eligibles of traditional Medicare population make up 18% of the traditional Medicare population. Okay? However, they make up almost 40% of the total cost spent, right? So here's the thing. In fee for service, remember, I want you to come in sick because that's when I get paid. So I want I call them the health nomads. They go from place to place, right? They go from ER to ER. And so because they never attribute it and because it's paid when you go to the ER, but it's not necessarily paid if you go to outpatient because of the backwards fee for service system. So they go to an ER, they get a scan on this broken arm, and then they're still having trouble with it. So they go to a different ER 2 days later. And the doctor says, well, let me see your scan. And he says, oh, it's on the system. It goes in, the HIE is not working, the Health Information Exchange, shocker. Or the EHR isn't interoperable with another EHR. They can't get it. So what does the doctor say? Nurse, let's order another one. I can't get it. Not because the doctor is malicious, because we have a system that is not working. Okay? Now I want to reduce the total cost of care because now I'm getting paid whether I see you or not. So I prefer not to see you so much, right? So now I say, gosh, I'm paid the most if I lower the total cost of care of my population. I have a particular population that's costing me over twice what everybody else is costing me. Let's figure out how to keep them home. And so, for example, one of the very early shift in value-based care was in Maryland. They were one of the first all-payer states, which we're seeing more of. Vermont's rolling out, other states. And one of the biggest hospitals there found that they could spend $1 million a month on Uber or Lyft and save money.
Wow.
Because they were on value-based care, they were able to focus on where to save money and what to do. And they could spend that money however they wanted to, which means better quality of life for the patient. Because now you're not concerned with having me sit and wait for 5 hours. Does that help answer your question?
Yeah, absolutely. So we only have about 5 more minutes. So if there's anyone watching live and have other questions, I think Dr. Kumar has another great question. I think maybe you could answer. That one's going to be a long answer. Maybe you could answer that one offline. And by the way, for those of you who are watching the show live or watching the recording, because this will be for evergreen on my page and on LinkedIn, please let us know if you learned something from the episode, if there's questions you have, and connect with Gail or myself as well. Also, I just put in the chat the link to your website, which is healthBZ.Academy. Tell us about the academy that's starting on Wednesday.
Thank you. I'm so excited. I'm so
Tell us
excited.
A little bit about that.
So,
yes.
So it's starting with a 10-week course that we've developed over the course of the past 2 years that does the entire history of healthcare and gives an overview in all of the pieces, how it was, how it's moving, how to be successful. All of that will then be recorded and available in modules with continuing education credits, as well as ebooks, materials. I'm also working on a book that is far along, and this group, I call them Cohort 1, will have access to all of this before anybody else does and be able to interact with it. This Cohort 1 also gets open office hours, which nobody else is getting. And so the idea is that together, we're going to build a place where we can demystify the business of healthcare for everybody. And in doing that, we're going to make healthcare much better. And we're also, there's nothing wrong with profit as long as we're doing the right thing, right? Let's stop profiting off the backs of our doctors and patients. And instead, as we profit value-based care, then we make it better for all of the stakeholders. So I'm super excited.
Outstanding. I've posted the link also in the chat of your LinkedIn. So if those of you who are in my network who are not connected to Gail, please send Gail a LinkedIn Connect request, because this is going to be an ongoing conversation. Gail and I decided today that we had so many different things going on in our brains that this is going to be a regular thing. And from a networking perspective and connecting. Well, last question, and then we'll wrap up. Gail, let me ask you this quick. This is the one that's really it's been on my heart about this a lot.
Yeah.
Young leaders. I teach. I spoke at VCU for their MHA and MSHA program last week. I've spoken at a lot of different ones. Where are the opportunities for them to grow as leaders in relation to value-based care? And I would love for you to maybe even talk about what are the career opportunities that might come out of it as well. A lot of people that follow me are young leaders as well. Your thoughts on that?
Amazing. I mean, I would put a big yes with a capital Y, right? Because everybody's learning it. It's not hard to become an expert. I will tell you, I just want your young people to hear this. 4 or 5 years ago, I was doing a project for a client, and I didn't know what a CPT code was. Now, people are like, okay, I don't know what a CPT code is. Exactly. A CPT code is the very basis of all payments in a fee-for-service, meaning it's really like A and B on your alphabet. Mm-hmm. And I didn't know it. And this was just 4.5 years ago. And now I've become like an international expert in this. I'm telling you this because if I can do it with no formal training, and now I'm going to be working with you, you totally can. And the career options, I believe that almost all of the business of healthcare careers are going to be given to people who understand value-based care. And you can very quickly move up the ladder if you show your expertise. So there's quality. There's numbers, there's care coordination, a great career from somebody who gets a nursing degree. Mm-hmm. There is all of the technology that has to support this, remote monitoring, all of the EHRs. There is patient communications. Who's going to train the patients who now need to be on governing bodies? All right, who's going to train the governing body on how to now include a patient? Yeah. Right? Sales and marketing, communication. All of your communication has to go through CMS now. Like most people have no idea, right? So pick the thing that you're passionate about And I can almost guarantee you that there is a solid career for you in value-based care in the coming years. 100%.
Absolutely. Gail, I love that. And that's a great way to wrap up. For those of you who don't know me, I'm Marion Spears-Carr. I'm the managing director for Healthcare and Life Sciences. We're an international executive search firm based in Chicago called Comar Partners. I'm based in Georgia. And obviously, if you don't recognize my accent, I'm from North Carolina, but live in the mountains of Georgia. Gail, thank you for being on the show.
Thank you.
We are going to have more conversations. Please connect with everyone. Thank you for being here. Dave, checking in from Avalon, New Jersey. Dave, it's good to see you in the chat. If you have questions, please put them in there. Go ahead.
Yeah, and it starts Wednesday. So, but anybody who registers before we actually start has open access to the community ongoing. So all of these like amazing questions that Dr. Kumar is asking and some of the others, there's going to be a permanent home for this so that we can really start all working together in community around the academy. We'll all be students and we'll also all be teachers.
I'm looking forward to seeing the growth and everyone. And have a great. Thanks for joining us on a Monday afternoon. Normally the show's on Friday. Gail, thank you for joining us. I got one last comment coming in. Dave McClung says thank you for the shout out and glad to have you. We're going to end the stream today. Great to have everyone. Talk to you soon. This is Healthcare Thought Leadership. I'm Marion Spears-Carr and this is Gail Zahtz. Have a great day.
Thank you.